Greetings, I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to the final webinar of our 2023 ANAwareness Week. In a moment, we'll hear from Dr. Rick Friedman and Dr. Mark Schwartz and their presentation of decision-making in complex acoustic neuroma cases. First, I'd like to handle a few quick items. If you have a question during the presentation and you're watching on Zoom, you can just write that in the Q&A section, which can be found at the bottom of your screen. If you were joining us on Facebook, your questions can be written in the comments section. We may be able to have those questions answered as we go through the presentation, but afterwards, we'll get to as many as we can. Captions are available for this presentation. You could turn those on at the bottom of your screen as well. This presentation is being recorded, and you'll be able to find that in our webinar library on the ANA website at anausa.org. That's also a terrific resource for so many topics you may have an interest in. Lastly, a reminder to keep an eye on our social media. We're on Facebook, Instagram, and LinkedIn. You can learn all about the resources available and how you can be more involved with the ANA. And now, doctors, if you'd like to introduce yourselves, we can get started.
We'll do that if we can. I think we're on here. And hi, Mark Schwartz, and I'm here with
Rick Friedman. Hi, everyone. Happy Friday.
So I'm going to share a screen here. I'm not sure if this is going to be the usual way that you hear presentations from the experts and specialists giving these webinars. Topic is, I think, a really interesting one, but also one that doesn't fit into a category of it's complex decision making. And for something like this is by its nature very individualized. So I don't think there's certainly a few things that are clear, but in most cases, either in the big picture or even in the details, everything about decision making is individualized. It's based upon specifics of a case. And so I thought we would just show a bunch of cases, try to demonstrate some ideas and principles, answer any questions, generate some sort of discussion and thought. Let you sort of know how our minds work, how the minds of any kind of experienced physician work when thinking about these sorts of things. I'm going to try to share a screen here and then get up this presentation, which is basically just a bunch of MRIs. I will say that we're not going to get into specifics of the individual cases, and we've kind of changed the facts a little bit to protect anonymity because we don't want to be actually talking about actual patients. We want to make sure that we're not doing that. So I'm sharing a screen. So when I talk about a patient, I'm kind of by nature have to I won't say make up, but have to change details in order to make it something that we can actually do. And so the first thing I'm showing is just an MRI of a relatively small acoustic neuroma, not tiny. This is a classic kind of a case. There's a textbook picture of a tumor that, as you can see, or maybe not, extends into the internal auditory canal with a little bit coming out on the inside of the skull towards the brainstem and cerebellum. And I can't use there's no way for me to use a pointer here, is there? Pointer's not working, which is not going to make things. Maybe I may come out of this presentation mode just so that I can use a pointer. I'll make it big. I'm going to do this and try to make this big. I want to use a pointer here, so
You can just hit that green.
Well, that looks good.
that's better. Okay, so I'm going to do it this way so we can use a pointer. So just a little bit about MRIs, just to make sure everybody's on the same page here and understands. So when we look at MRIs, an MRI is basically MRI makes a three-dimensional representation of what's going on in somebody's head. And then in order to look at it, we slice it in one of three planes. So if you're thinking about a cube and looking at it in slices from top to bottom or from side to side or from front to back, that's what the MRIs are. The typical ones we look at is this one, which we call axial, which is sort of the one from top to bottom. So imagine looking at your head it's actually not top to bottom, it's from bottom to top. And by convention, we're always looking from the bottom up. So this is like looking at somebody from their feet up when they're in the MRI machine. So right is on this side and left is on this side. So this is a right-sided tumor. The brain stem, cerebellum, this is in contrast enhanced, we say T1. You see it says T1 down here. Ax is axial. So I talked about axial before. So the T1 images are the ones where the IV contrast works to light up the tumor, which you can see right here. Fluid around the brain is dark. Bone is very black. Air is also black. And you can see the hole in the bone. This is the bone directly in from the ear, we call the temporal bone. You can see the cochlea, which is the structure right here, and the balance canals, that's the inner ear structures. A brainstem is over here, and the nerves are going to be going around. So this is a T1. I'm going to show the other one, which I'm going to show is called T2s. Those show other details. The difference is T1, the fluid is dark. T2, the fluid is bright. T1 has contrast as a possibility to light up the tumor. T2 does not. So that's just the basis of looking at MRIs. We're going to show some coronal pictures also, which is like looking from the front to back. So that and I'll show you, and I'll describe that when we get to that. So this is just kind of a standard case. So we're talking about difficult cases, but I sort of chose this one as something to say this is like a very typical case of somebody that we see. It's not a very large tumor. So it's not one we say this is so big you need surgery. It's one where we have to have a whole discussion with the patient about what the right thing to do is. And obviously every patient faces a choice of observation, surgery, or stereotactic radiation. Depending on the details, this is a case where you might say one is better than the other. What are the factors that go into it? Tumor size, and again, this is a small enough tumor, patient age, symptomatology. Big one, of course, in these cases where we can't say there's an absolute right answer about what to do is patient preference. So we might, as a very general sense, say, we know that hearing loss is a high risk no matter what you do. We know that other than that, you're likely to be good. We know that acoustic neuromas affect how people feel, largely in terms of just by their nature, hearing issues and balance issues. We can't predict what any one person is going to do, but when we look we can kind of guarantee that a week after surgery, you're going to feel a lot worse than a week after doing nothing or a week after radiation. But we look long-term at how people do. On average, they kind of feel about the same. But it's very different to have one treatment than another. So a lot comes up to what the patient is most comfortable with. So if this is a 65 or 70-year-old patient, hearing is already compromised. They're not eager to get something done. Obviously, we can watch first and see what happens. This is the first one. That's when we saw this one. And now in a year, we go from this to this. Now the tumor is growing. And it's growing very definitively. And now we've got to decide what to do. I mean, how do we make that decision? Again, I just went over everything. So can we keep watching it? I mean, certainly there's no imperative to treat as an emergency, but this is a tumor that's proven growing. Does the fact that the tumor is proven growing mean guarantee it's going to grow in the future? There's no guarantees. It doesn't guarantee anything, but the odds are very, very high. And we would probably say that, this is one that's proven its growth and it needs to be treated. And now it's time to choose. What do you want to choose? It comes down to those factors. It comes down to tumor size, and it's still small enough to be radiated. Obviously, it can be operated. It comes down to patient age. So for a young person, we'd be probably more likely to say, this is one that you would want to think about surgery. Of course, it's a patient choice. Older person, we typically think of radiation first. Obviously, there's a big gray zone in the middle, so it's very hard to say there's an absolute there. Tumor growth rate. I mean, this is actually a tumor that's grown pretty substantially in a year. It's grown 5-6 millimeters in a year. That's pretty fast, and that may mean the radiation is a little bit less likely to be successful in terms of stopping tumor from growing. That would be a reason to recommend somebody think about having surgery for it. Hearing, now hearing is also going to probably not be good one way or the other. But if hearing is already bad, we don't have to worry about it. With surgery, it's kind of all or none at the time of surgery. If we're trying to save hearing, radiation, you wait and see what happens over time. In the short run, radiation looks quite good, but in the long run, not very good. But again, it comes down to patient preference. Another thing is the tumor may be getting big enough to be starting to push on the brain, on the trigeminal nerve, and causing some facial sensory symptoms. And that may be another reason to think that we want to do something that could relieve those symptoms. So the point of this is that even the simplest case is a complex case in many cases. What do I in many cases do when it's one of these what we call equipoise? It could go either way. I try to get cues from the patient. I mean, so in talking to the patient, it can become very clear what they're more comfortable with just by the way they react. My memory, one of the most difficult patients I saw was a patient who I thought was somebody who could go either way, and they were sitting to me like with a stone face. I couldn't get anything out of them about what made them think that they would be more comfortable with one versus another. Because obviously you can look at, I look at somebody's reaction, and when I start talking about surgery and they're thinking, oh, that sounds appealing to me. And then I talk about radiation and they're, I just want to get this taken care of. It becomes pretty clear. And sometimes it's the other way around. Patient who said, and I said, I'm not really getting anything. It can go either way. And if it were me, I'd have surgery, but I don't want to tell you should do that if you're not comfortable with that. And he actually said, well, I'm trying to not show any emotion because I don't want to lead you. I don't want to lead you with what you're telling me. And what I've learned in doing a lot of this time is it's useful for us to be led by the patient. It's useful for us to try to get an idea of what the patient is most comfortable with, either from what they say or how they react. And that to me is an important part of the decision-making process.
Yeah, I would agree. We see, I don't know, we have Melissa here also. I think we consult with about 400 or more patients a year. We're known for our surgical skill. We also do radiation, as Mark said. So we feel comfortable offering all options, but tend not to offer radiation for younger patients just because of the unknowns. Although the risks of malignant transformation from radiation are low, since we've been here in San Diego together in 6 years, we've inherited 3 that transformed. And so those are things patients need to know. They need to know that there are risks to all forms of treatment. I think I'm blessed to say that since Mark and I have been operating together for probably 20 years, we've never had a surgical mortality, and we've done close to 2,000 cases together now. So we know where we're coming from. It's so true, and it's part of the joy of helping patients like you all, is that you're well informed, and unless the tumor is giant and causing terrible symptoms and brainstem compression, we have an open dialogue, and we thoroughly go through the options.
Okay. Now I'm going to show a really bad case. That's not bad case from us. But I think this is, and I want to show this at the very beginning, because I think, obviously, if you're coming to this as a patient or somebody who's has an interest, who's not an expert in the field, it can be very difficult to know what's credible and what's not credible. And you have to have your guard up a little bit, and to understand, like, what are some warning signs, or as we say, red flags. And I want to demonstrate what I think is probably the biggest, what I would call a red flag. And so this is a patient, a younger person, a younger guy with an obviously large tumor. This is one we would look at it and say, I said the last case was like, this could go any way, but this is a case we look at, and this is a big tumor. It's really dramatically pushing on the brainstem. This is a case that needs surgery. So that first big decision of what needs to happen is very clear cut. Now, of course, there's some details. Details are what approach you take, which I think is a less interesting issue, because there's several different operations you can do. You can do translabyrinthine, you can do retrosigmoid. That comes down to surgeon preference in large part. I say that when I go to meetings, we used to have huge debates about what the best approach is. I think that's less of a debate right now, because we just let people do what they're comfortable with. But to me, the big detail is, how aggressive are you with surgery? So in the old days, you're having a surgery for a large acoustic. The goal was take the whole tumor out, and that would carry significant risk to the facial nerve. And that's really changed over time, because for a few reasons. Number one is we have MRIs. So if you go back 30, 40 years, there was no MRIs. You didn't know what's happening if you left a little bit of tumor, and tumor could grow back, you wouldn't know it. Number two is we do have radiosurgery as an option. So right now we're saying this is a case that needs surgery. But if we left a little bit of tumor and did see it growing back, you're not necessarily committing somebody to more surgery every time. Number three is what we see is when we leave very small pieces of tumor, typically on the facial nerve, and really doing translabyrinthine surgery on the facial nerve. And we're not sure exactly why. It may be because we cut the blood supply off by coming around it, but leaving small fragments, they tend to just sit there. And if anything, they're more likely to shrink than they are to grow. So we know that leaving a small white dot on the nerve doesn't lead to bad things. But we also see people that are saying, let's not be aggressive. Let's get this 3.5 centimeter tumor down to 2 centimeters, or even 2.5 centimeters, so that it's small enough to just radiate the rest. Which sounds in one way like it's the best of both worlds. We can do the little bit of each, but it's also kind of the worst of both worlds. And so this is a patient who had surgery somewhere else. They did a translabyrinthine operation, and actually during the approach injured the facial nerve. So they injured the facial nerve during the approach to the tumor. Facial nerve was out before they got to the tumor, and then they stopped. Okay, so they stopped and left the tumor. Go to this one. Stopped and left the tumor. This is the approach that was done translabyrinthine, which is through the bone to get the tumor. I didn't put the MRI up, but the tumor is still there. And then the patient came to us with a paralyzed face that didn't recover. Actually, tumor now bigger than it was at the time of the initial surgery because it's a growing tumor. I'm not here to. You're thinking, well, I'm really criticizing these surgeons for the technical error, and actually that's not the point here, because technical errors are something that can happen, and I don't want to be too harsh in judging that. There could be a funny anatomy. We don't know exactly what happened, but my criticism here is, why did they stop? So we have a tumor that needs to come out. It's basically a life-saving operation. It's a big tumor. It's going to cause death. We know there's a risk of facial nerve injury. There's no way to avoid facial nerve injury. These, why would you stop? And the reason that I can think of is an error. It has to be an error in counseling. So when we see a patient with a tumor like this, we go through the risks, and I think we have very good results, but they're not perfect. We know that there's a risk of facial nerve injury. We know that there's a risk of a bad facial nerve outcome. We know that can be permanent. We know that can be something that affects somebody's life in a very dramatic way. And we make it as low as we possibly can, but we can't make it zero. It's always a risk that you can never eliminate 100%. And I think it's important to counsel a patient that way. Say, we're going to respect your facial nerve, but we also have to respect the tumor, because we want to also accomplish the goal of the operation, which is basically to get the tumor out that we can safely get out, have this tumor cause as few problems as it can possibly cause in the rest of your lifetime. But if you're a 40-year-old person, we want you to live another 40 or 50 years and die of something entirely unrelated, and have this not be something that causes on and on problems. My suspicion is that this patient was counseled, we're just going to debulk the tumor and leave some tumor and not hurt your facial nerve. Don't worry, it's easy. It used to be hard to take these out because we had to be aggressive about taking it out. Now we don't have to be aggressive. We can just debulk the tumor. We're not going to go near anything. We're not going to go near anything important, and we're going to leave tumor, and then we're going to treat it with radiation, and everything's going to be fine. Don't worry about anything. And if you counsel the patient then you have to stop, because you just counsel them you're not going to hurt the facial nerve, or you're going to leave a lot of tumor in order to avoid hurting the facial nerve. And that's impossible. I mean, no matter what you do, there's risk to the facial nerve. So to me, that's the biggest red flag, is when you talk to somebody who says, don't worry about it. It used to be hard, but now the way we do it now, we've made it easy. And I'll tell you that from my perspective, it's not, in some ways it's easier now than it was 40 years ago now. I mean, we have better instruments in the operating room. We have better anesthesia. We have better medical care. We have better everything. So the risks are way, way, way less. But the expectations are also much, much higher. So if we go back to the old days, everybody expected a high risk of facial nerve injury, and it was not a good outcome, but that's what you got. And so things haven't gotten easier. Things have gotten harder. Mm-hmm. And you have to respect these tumors, and you have to make sure that you're not selling the patient something that's just unreality. And to me, that's the big red flag, is not respecting the tumor and saying, don't worry, it's going to be easy. That's not that, and it's not something we can say to the patient. And obviously, there's a big tumor. You have a tumor like this, you know there's a risk of facial nerve injury no matter what you do. Smaller tumor, that risk is much, much, much less. But that doesn't make it easy also, because yes, the surgery is a shorter operation. The risks of anything happening are less, but the stakes are also higher. I mean, the expectations are higher. So there's a sliding scale. The bigger the tumor is a harder operation. It's a long day. It's a hard operation. We're in there up to our elbows a little bit. But we know that we know what the expectations are. But we're a very small tumor. Yes, it's going to be a smaller operation, easier day for us. We're going to get out earlier. We don't have to worry so much about that. But the expectations are so high that it's still very hard.
Yeah. I agree with everything Mark is saying. I think Mark is in some ways being humble. We rarely do a subtotal. So our plan going into the care of patients that have surgery is that this should be their only treatment. So I would have to say almost never do a subtotal. Our facial nerve results are outstanding. We have less than 1% risk of a facial nerve paralysis that's permanent. And I think what Mark does spectacularly is what he was describing, the near total, where we leave a dot where it's stuck on the facial nerve. And I was talking about this with one of our fellows. I can't think of a patient that's had a near total in our hands that's required anything else, surgery or radiation, because we devascularize the tumor. And that's, this is acoustic neuroma care, appropriate care, requires a tremendous amount of training and experience. And so, I personally hate to see it when we inherit a case like this. Stuff happens, as Mark is saying, not being critical of the surgeon. What bothers me more is when I see young people that have a subtotal removal and then still have tumor's still going to grow. It requires another treatment. In my opinion, that's not okay, because we're putting a patient through a craniotomy. We want to do the right thing the first time.
And also, to be clear, this tumor that's a 3.5 centimeter tumor that's maybe growing a 0.5 centimeter or more a year is biologically not the same as a 1 centimeter tumor that's growing 2 millimeters in a year. When we talk about radiation and the radiation effect, yes, you can't extrapolate the results of that small tumor to this tumor.
Right.
So if you leave a big piece, you don't change the biology of the tumor, it's not going to have the same kind of response as that small tumor that may be a really good candidate just to radiate. And the person doing the treatment who says, I have a 95% chance of success, that's not extrapolated to a case like this.
Right.
And the data shows that. And I'm not really showing data in this, but the data does show that.
Right.
And then yes, and when we leave a very small piece, the odds of the tumor growing. And now again, I talked about living 50 years and dying something unrelated. We don't have 50 years of follow-up, so nobody can say we know what happens over 50 years. Everything is not 100% known, but very rarely do those small ones grow. It happens enough that you have to follow. You can't forget about it and not get MRIs, because it can happen, but most of them don't.
I would agree.
Yeah.
And the good news about this gentleman, his face was out. We removed the tumor entirely. We have a wonderful facial nerve reanimation team here, Dr. Green, and he had reparative surgery and is doing really well.
Okay, now I'm going to go to the opposite end. So as Dr. Friedman said, we have a practice where we're known for surgery and people come to us for surgery. So we see people with very small tumors, so to be very clear, this is about a 4 millimeter tumor, which you can see. I think you can see right here. And of course, when somebody comes to us with a 4 millimeter tumor, there may be some exceptions. If somebody has horrible dizziness, nothing makes them better, say, listen, we just got to get it out. We're going to probably make you feel better. But for most cases, when somebody comes with a tumor like this, kind of the immediate reaction is, let's just keep an eye on it. Let's not recommend doing anything. But we have people that come to us and say, I can't sleep at night. It's driving me crazy. I need to do something. Can't you take it out, please? Then we've got to then be able to counsel the patient whether we think that's a good option. Can we convince them not to? Can we say, okay, we can go ahead and we'll make you feel better? We want to do what the patient wants. What are the actual risks? So when we do this for a patient like this, with a tumor like this, we have to look at the specifics of the case. And as I said before, if they have vertigo and it hasn't got better in 6 months and they can't work and they can't drive and nothing's worked, yeah, we're saying, listen, we can't guarantee it, but by taking this out and by cutting the balance nerve, We don't create a normal situation. We may relieve that irritation and make you feel much better, which is what our experience is. We should go ahead and do it. We're listen, really, you have to have real expectations about it. So let's also assume these patients have very good hearing, right? So if the patient comes in and is already deaf, we don't have to worry about hearing, but if they also still have very good hearing, we've got to worry about it. So this is, I said before, the other, we look at axial MRIs. This is what we call a coronal MRI. So this is the same, look at your head the same way, but instead of going from bottom to top, we're going from front to back. And you're not looking at yourself in a mirror here, you're looking at somebody else. So same thing by convention, the right is on this side and left is on this side when you look at these, and this is a right-sided tumor. And it's a very small tumor. It's in the canal, which you can see here. This is a T1 with contrast. What we look at is say, well, this tumor is, here's the canal, is way at the very top of the canal. And it's at the end, but that, if we do a middle fossa surgery, is going to be an easy reach. We're going to come right down to the tumor. And remember the anatomy. In that canal, there's basically 4 nerves. There's the facial nerve, there's the cochlear nerve, the hearing nerve, and there's 2 vestibular nerves. There's a supravestibular nerve and there's the inferior vestibular nerve. And the tumor can grow from either the supravestibular nerve or the inferior vestibular nerve. The facial nerve and the supravestibular nerve are going on top. The cochlear nerve and the inferior vestibular nerve are going on the bottom. This is a tumor that's clearly coming from the superior vestibular nerve, away from the cochlear nerve. It is next to the facial nerve, but so that there's not zero risk. But this is one that we would say has a high chance of saving hearing, and we're very likely to help the patient and have them be very satisfied with their results if they're inclined to want surgery for this. If somebody says, I don't want to do anything, I think nobody would say, you got to do something. This is one, our first recommendation would be, let's repeat a scan in 6 months. But if the patient says, I can't sleep at night, I need to do something, this is one where the patient comes and we say, okay, we can help you.
Now, this person came across the country for it. And I'm thinking back about what Mark's saying. When we both were in the room together with him, we counseled him, you just don't have to do this. Mm-hmm. And he said, well, I'm dizzy. And I know that over time, I'm going to lose my hearing. So why not get it while it's smallest, which is a reasonable argument. And anyway, he underwent successful middle fossa and we saved his hearing.
Yeah. Now, this is a little different view. Now, on the other hand, this is another small tumor. And I wish I wanted to show the same coronal as that one, but it didn't project very well. So this is axial. The tumor's on this side, another small tumor. It's a little bit bigger than the other one. It's about 5 or 6 millimeters. It's a very similar story in a patient. And I will tell you that this is somebody who the counseling may be a little bit different, because where that other one was a superior nerve tumor, this is an inferior vestibular nerve tumor. And you have to maybe take my word for it, but the cochlea is right here. You can see the tumor at the end of the canal, and there's like kind of a little nubbin pushing into the cochlea. So this is a patient with an inferior nerve tumor, still has good hearing, and comes with a very similar story, and wants to save the hearing. We have to counsel this patient. Yeah, we can do the same thing. We can do a middle fossa. We get this tumor, but because this tumor is next to the cochlea, next to the cochlear nerve, instead of away from the cochlear nerve, our odds of success in preserving hearing are much less. And so the patient may say, I don't care. I'm going to lose my hearing. You're telling me it's under 50% chance. I still want to do it. But we have to be able to understand what the odds are in a specific case. Where one patient, we can say, well, yes, one case, well, it's never slam dunk and there's always risk. We say, we think we have an 80% chance or more maybe of saving your hearing. Whereas the other one, it may be less than 50, even though it's almost exactly the same story. So the counseling is very different based upon the very specifics of the case.
Agreed.
Yeah, here the two are together. So this one is on the other side, but if we were here, it would be, this tumor would be down here instead of up here. And it makes a big difference in terms of risk, chance of hearing preservation. So I talked before about T2, and this is a T2. So T2 is fluid around the brain is bright instead of dark. We actually see a lot more detail with the T2. This is maybe the cuts tend to be much smaller. So under a millimeter between each of those cuts going from bottom to top. We can look at the normal side here and actually see the canal, see the cochlea, which shows up much nicer. Everything is fluid is bright. See the balance canal, see the nerves coming in. And on this side is the tumor. And this is a tumor that I don't have all the MRIs, but a tumor that's growing in a young patient and growing relatively rapidly. And somebody who we may offer middle facet surgery to try to save hearing. And I can't demonstrate 100%, but remember, the middle facet were coming from above. So we have to look very precisely at these pictures. I'll show you here. Here it is here. Get these pictures and try to find where do we think the facial nerve is. So if you go back and talk to a lot of people, they'll say middle facet surgery is dangerous for the facial nerve. And honestly, in my experience, going way back to the beginning of my career 20 years ago, I think it was a little bit more dangerous to the facial nerve. But what's changed since that time, a lot of things have changed, but the one thing that's made a dramatic difference is these MRIs. So we had MRIs back then, but we didn't have MRIs that had this much detail. And in many of these cases, in a tumor about this size, we can see the facial nerve. So we can tell that, and I'll tell what the facial nerve is, and I can tell you this right here is the facial nerve if I follow it up and down. About 3/4 of the time, the facial nerve is in front of the tumor. So if you imagine coming down from the top, if the facial nerve is in front of the tumor, you're not coming down on the facial nerve. About 1/4 of the time, the facial nerve is on top of the tumor. And if you're coming down from the top and you come to the facial nerve, that makes it a very difficult operation. Back in the day, we couldn't tell, but now we can tell. And so when we see the facial nerve in front of the tumor, which is about 3/4 of the time, we know that we can safely get in there without again, not zero risk. There's nothing that's zero risk without additional risk to the facial nerve and the middle facet surgery, which takes expertise, and you can talk about that. It takes a real expertise to do it, and not many people can do it. If we can show the facial nerve in a favorable location, that is a great operation, and gives us the best chance of saving hearing for a case like this. And not many places do it. This is a zoom up of the coronal, and this is the tumor here. You can see the end of the canal. I would say this is the facial nerve going in front of the tumor. I wanted to try to find a picture of one on top of the tumor, but we don't keep as good records of the people we don't operate on, and so I couldn't find one. But we look at this very carefully every time.
The other thing about this image is in counseling patients about hearing preservation, remember everything white is fluid. So this is what we call a fundal cap. And I'm always amazed at patients that ultimately wind up with us have done a lot of homework and ultimately found us because of our high volume. And they come in and say, I have a fundal cap, isn't that helpful? And the answer to that question is yes. It seems as though hearing preservation for a tumor, unlike that tiny little one where we knew we had a very, very high chance of saving hearing, but hearing preservation does seem to be better in tumors that are not pushed up against the base of the cochlea. So this, even though it's a larger tumor, it's still favorable. Facial nerves in a good location, fundal cap, tumor small, and then there's fluid between the tumor and the brain.
Yeah. And so this is larger for middle facet. It's not larger for all cases.
Right.
All right. Now we're going to get into something that maybe is a little bit more, maybe not apply to most people, but I think is just something I'm going to point out. This is a patient who, and I don't have the MRI from before treatment. This is a patient who had radiosurgery. And actually the radiosurgery worked in terms of actually shrinking the tumor. The tumor is smaller, and radiosurgery was a few years ago, about 5 years ago, 5 years before this. Tumor is smaller. So in terms of control of tumor growth, the radiation worked. So the tumor has shrunk and is smaller. So it does work in terms of that. It works. It doesn't, it's again, it says pros and cons, nothing is, but it's an effective treatment in terms of stopping tumor control. The problem is, and here's that same picture. This is the T1 with the contrast. Here's the T2. Problem is the patient's initial presenting symptom was trigeminal neuralgia. And trigeminal neuralgia is facial pain caused by pressure on the trigeminal nerve, which is a nerve of sensation on your face. So we talk a lot about hearing and balance nerve and the facial nerve. The other nerve which can be involved with these is the trigeminal nerve, and that's not going in the same place out here in the canal, but it's sort of on top of the tumor, going 90 degrees direction from the brainstem towards the front, And that's the nerve for sensation in the face. And here you can see that the tumor near the canal, which is right here. This is the very top part of the tumor, and it's pushing on the trigeminal nerve. This is the tumor right here. And this patient had trigeminal neuralgia before surgery. It actually got better for a year or two afterwards. And now comes back to us with horrible facial pain. On 3 medications for it, not working. Life is a wreck. And there's sort of 2 points here. The first one is I would say that even the people doing a lot of the big radiosurgery centers would tell any patient that if you have trigeminal neuralgia, that the best treatment is surgery. Sometimes patients won't refuse surgery and want to do radiation anyway, and it's an option, but they will recommend surgery to decompress the tumor and take the pressure off that nerve. It's the best way it's the best way to relieve that pain, and it's horrible pain. I don't know if anybody on the webinar has experienced it, but it's dramatically bad pain. But that's number one. And number two is we now are seeing this patient. Her hearing is still good. Her facial nerve is working, but she has intractable, horrible pain. This is still, even though the tumor is not growing, this is still a tumor that needs to be operated. So she needs surgery to have facial pain relief. And our problem was we kept telling the patient this, but her initial treating physician kept telling her that surgery was dangerous and that it was the worst possible thing and she can't have surgery. And it took 6 months or a year for us to convince her to do it. Is that right? Yeah.
Yeah, and she came to us unable to speak because it hurt so much. She was drooling because she couldn't manage, she couldn't swallow because it hurt to move her lips. We took her to the operating room. We really didn't touch the tumor too much because the radiosurgery showed at least that it wasn't growing at this point. And also surgery after radiation is potentially harder on the facial nerve. And Dr. Schwartz was able to decompress the trigeminal nerve. And when she left 7 days later, totally different woman, jumping up and down, hugging, I think bought us about 3 tons of cookies. It was just a wonderful life change.
Yeah, and the goal of surgery wasn't to cure the patient of the tumor. The goal wasn't to take the whole tumor out. It was just to take enough out to take the pressure off that nerve, because we know the tumor is not growing. We know that we don't have to take the whole tumor out. So in effect, it was actually a very safe operation, not a dangerous operation. But we had people. We did have direct arguments, but we have the angel and the devil on the shoulders is I think what it was.
Yeah. You know, this is I don't know if you all are familiar with Malcolm Gladwell's book about 10,000 hours, but you know, it's a 10,000 hours operation, and that's why patients should get multiple opinions. Because if you go to a surgeon who doesn't do this a lot, they're going to have trepidation and fear and scare you away from what may be the right treatment. So I can't emphasize enough that multiple opinions and experienced hands. I know that I think we're going till 11 o'clock. Mark and I actually have a case going at 11 o'clock. And so we could either present another or we could take questions. I see there are 3 in the Q&A. Maybe we present one more and then answer some questions.
If you want to go ahead and present one more, we have those questions and we have a handful of others.
Oh, okay.
I'm going to skip this one. I'm just going to do one more. Okay. Just one more principle, the things that we think about that I think are relevant, and this should be pretty fast. So here's obviously here's another huge tumor. That's going to be a big operation. What else are we worried about? This is something totally different from anything you probably heard. So when we look at the surgical planning for this case, which we would do translabyrinthine, but even if you did retrosigmoid, it would still play a role. This is an anatomical concern. So why is it called retrosigmoid? Because there's something called the sigmoid sinus, which is a big vein that drains the blood from the brain. It's a paired structure, and so retrosigmoid is behind the sigmoid. Translabyrinthine is actually, we could also call it presigmoid, because it's in front of the sigmoid, but we have to preserve it. About half the time they're about even in size, and about the other half of the time they are unequal and one side is bigger than the other. Actually, usually it's the right side that's bigger. In this case, it's the left side that's bigger. I think we would all, but when we operate around the sinus, it increases the risk of surgery. We don't. We could. The small one's not important, but when you have a big one, it's a critical structure that can't be injured, just to be aware that these are the kind of things that if you have a lot of experience, and you have put it in, we're as surgeons, we're looking at other things than just a tumor. And there's a lot that goes into decision making and our thoughts about how we approach these tumors, including everybody's anatomy. It has nothing to do with the tumor itself. We would both be happier, I think, if this tumor were on the other side.
Yeah. Yep. Yeah. So there's just so many things to consider when being treated. I think that's the message. We see a lot of complications from other places, obviously, because we see a lot of patients, we have a lot of experience, and ultimately some of those cases wind up in our hands to fix. I hope this was educational, and I think now Jim will take some questions.
Yeah, let's go ahead and do that. If you want to stop sharing your screen there, Dr. Schwartz, it'll just be us. There we go. We can go ahead and do that. We do have a handful of questions. Someone on the chat here has said that they've heard that surgeries can take typically 4 to 8 hours, but they've also heard they can also take 12. Can you clarify why a surgery, what the different situations would be there?
Yes, I feel very strongly about this as well, because something patients and people need to understand is not only can there be intraoperative complications that could be life-threatening, which are very, very uncommon in experienced hands, but the postoperative issues are important too. Long durations of surgery are harder on the body and subject the patient to a greater risk of postoperative complications like pneumonia or like clots in the leg. It's just I think when you have a patient on the table for 12 to 15 hours, they can get sick from just that. So, again, it's you don't want a short surgery with part of the tumor taken out. You want an efficient surgery with the appropriate care being given. Again, the 10,000 hours we've had together, and we have a dedicated team here at UCSD. This is all we do in our practice is acoustic neuroma and some meningioma. It's a well-oiled machine and things go fairly quickly. So our middle fossas average about 3 hours. Our retrosigmoids average about 5.5 hours, and our translabs, usually bigger tumors, probably average around 6 hours, 5.5 to 6.
The thing that can't be controlled is tumors. Like a big tumor is going to take longer than a small tumor, and there's also sometimes anatomic things. So I said anatomy. So I'll tell you that's the tumor. The tumor part depends on the tumor size, but it also, like to say for anatomy, and I think with the translab surgery. I showed that the same with science, but people's whole anatomy is different. And some people have easy anatomy, some people have harder anatomy. And so what might take 2 hours in one person takes 3 or 4 hours in another person, just anatomically. But these are a big tumor is a big operation. It's going to take hours and hours and hours, but being efficient is important. And like that case that you can get out and be done by dinner time, before dinner time, is great. I'll tell you, the one that goes all night is not great. And understand also, it's not just, you don't get your A team help. We stay till the end of the case, but everybody else in the OR switches, and you don't get your A team at nighttime. It's good to be done when the evening shift is done. It's good to be, we have block time till 7 o'clock, and be finishing at least the hard part of the case by 7 o'clock. That's a big deal in terms of who's helping in the operating room.
Yeah.
Good. You said on the first case, we have a question here. You said on the first case that radiation is good short term, but not long term. Can you explain?
For hearing. Yeah.
Yeah, for hearing.
For hearing. So again, we're not representing data, but there's a good paper from the Mayo Clinic The problem is, how do you follow patients up? So there's certain, obviously for tumor recurrence, things like that, it doesn't happen right away. But for most things you do with surgery, you know your result right after your result right after surgery, or maybe a year later, it happens. When something happens over time, it's much more difficult to get follow-up data. And people are usually happy to get their MRIs. I mean, they want to know what's going on. They get the MRI. Facial nerve is just a matter of going in and smiling or sending, and people do that. But following hearing is more difficult. People are often reluctant to get hearing tests, cost money. And when you look at long-term data for hearing, in many cases, you may start with 300 patients, and you're make your conclusions on the basis of 100 patients, and whether those 100 patients are representative of the whole group is very unclear. It was the Mayo Clinic. They actually sent all their patients a $100 check and said, "Here's $100. Please get an audiogram," and they got a very high response rate. And they saw that their hearing results 1 and 2 years after treatment were very good. But when you look 5 and 10 years out, and you have really mostly everybody's result, it was really poor.
Yeah.
So I wouldn't consider it to be a treatment. I mean, we can only be successful with surgery in a certain category of patient. It's not like we can. There's a lot of patients we know the odds are really low. We know it's not even worth trying. But for selected patients, we have very good results. But even that's high risk. I mean, having acoustic neuroma, that's the highest risk no matter what. But nobody should be going in and telling patients with any kind of treatment, or including no treatment, that looking out over many years, expect to have good hearing on the side of that tumor. I mean, it's a pretty select group.
Yeah.
One of the you had mentioned earlier that Dr. Schwartz, the patient wasn't giving you clues in terms of making the decisions. When patients are trying to make those decisions, what sort of questions should they be coming to the doctors with, in order to, I guess, prioritize maybe?
Well, like I said, we consult with a lot of patients. I spend a lot of time on the phone. We have a free consultation system. And that's a question that I often get from the patients that have done their homework. The final question is, what question should I have asked? Did I ask, or should I ask? And the ANA, I think, put that together well in the handbook that you guys provide for patients to ask appropriate questions. It's going to be like any delicate endeavor, whether it's I'm at a loss for words. How many do you do a year is really one of the most important questions that a patient can ask. I really think that that's the case. I also love the way Mark counsels patients. We do a lot of hearing preservation surgery, but when we go through the risks and complications, even though hearing loss, in my opinion, is not a complication of surgery, it's a known risk. We say that your biggest risk tomorrow is to lose your hearing in that ear. Mm-hmm. Even to the guy that had the little tiny one, we said that's your biggest risk tomorrow. Mm-hmm. Fortunately, we saved hearing, and we save hearing more often than not when we try, especially middle fossa. But it's really a 10,000 hours question.
Yeah, what I'll say is, it's I know it's so hard. I mean, we have families, we have medical problems, and when you're dealing with somebody that you don't really know, it's so hard to know what's credible and what's not credible. It's so hard to understand. You have to be comfortable with the person you're talking to. I know that there's people with limited insurance and narrow networks, and I think having comfort with the person who's taking care of you is a critical thing. This is not something. I mean, I'll talk as a nurse. Every neurosurgeon you talk to is going to think that they are an expert. Mm-hmm. They're going to have, and they might, and residency is your 10,000 hours. So we keep saying this 10,000 hours. As a resident, you get 10,000 hours of taking care of people with neurosurgical problems, but that's all of neurosurgery. Somebody who's a brain tumor specialist even has their 10,000 hours in brain tumors, but that's all brain tumors. It's really, I would say, being treated by people who have a specific interest in this is really important. Now, even with that, you're going to get different opinions from different people, and you're going to have 4 surgeons. That means there's at least 5 opinions. But nobody, in many of these cases, it's a matter of working through it and making sense of one person versus another. There's lots of biases that come into play. I'm going to do another book, which is that Kahneman, the Kahneman and Tversky, Thinking Fast and Slow. The psychology of it is the people who get as much information as they need, really take care in making a good decision, but then end up kind of going with their gut instincts, as opposed to trying to drill down. The people that come in with 7 pages of single space questions, trying to think that they're going to work through 7 pages, 7 pages of single space questions, and by knowing the answers to those questions are going to be able to figure out what the best thing to do is, it's impossible. You got to get the information and then sort of go with your gut instinct and what's going to make you comfortable, what's going to give you the less chance for regret, what's going to make you happiest, what's going to make you feel best. That's the best way to make the final decision when there's really different options.
Yeah, I know we're running up on time. Just 2 quick ones more. You mentioned, we were talking about just a moment ago, talking about hearing. The question is, if surgery causes hearing loss in one ear, would that play a role in eliminating the tinnitus in the same ear?
Yeah, that's a good question. The answer is, it's not no. The answer is about 1/3 of the time the tinnitus does get better, even if the hearing is lost after tumor removal. But it is absolutely not an indication for surgery. So if a patient comes to me and says, I want my tumor out, and there's no other indication, but they say, I just want my tinnitus relieved, I would say that is not a good reason to have surgery.
No.
Okay. And then lastly, I guess when we're trying to make these decisions and everything, the goal is successful successful surgery, successful outcome.
Yeah.
How would you, I guess, define that? And, how would you help a patient with their expectations with defining that?
Yeah, here's another way that being part of your organization, Jim, the Acoustic Neuroma Association, has really made me, in my opinion, a better surgeon, a better doctor. For years and years and years, we would operate on patients. They would have their tumors out, maybe lost their hearing, maybe saved their hearing, faces were fine. And, in my mind, when I was seeing them before they went home, I was high-fiving myself. What a great case, what a great outcome. That is a great outcome from a surgical perspective. So I would say a great outcome is adequate treatment, meaning that we did everything we could to make this the only treatment this patient would need, and a good facial nerve outcome. That would be my feeling of a good outcome. But what I learned when we hosted the meeting in Los Angeles was about the new normal. And there is a new normal that we have to consider. That's why we are in constant contact with our patients for years afterwards. We're here for them because life does change. Having hearing loss in one ear, having only one balance organ working is a life change. So a successful outcome is a happy patient who understands that they have an acoustic neuroma, that it is going to change their lives, but with hard work and support, they'll get better.
Okay. Well, great. That was very interesting, very comprehensive. And, as we spoke before, I said, I think doing, handling, looking at each different patient examples is so important to helping other patients understand how those decisions are made. I think you both did just that. So thank you so much. I really do appreciate the time, and not just for this, but all the ways that you are involved with us. Dr. Schwartz, you just stepped off of our medical advisory board. Dr. Freeman, you just joined our medical advisory board, and that's just another way you're involved with us. So we appreciate all that you've done over the years.
And likewise, you are critical to the care of these patients. No question about it. What a great resource.
We appreciate that. And we appreciate everyone watching today. Thank you so much.
Thank you.
Thanks a lot.